I'd like you to address telemedicine, the online video chats, the virtual follow-up visits. Is that something that any of you are doing currently, and how does that look for the near future?
So I'll take the question of telemedicine. So I'll take the question because 2 days ago I got an email and they wanted to know if I was interested in telesurgery. Any of you know how to do that? Because I don't.
So that's pretty miraculous.
Right. So for us, it's not something that technically, if we're going to enter the scientific world that you mentioned earlier, I could see how it could happen, right? I could have a robot someplace, and if I'm a really good surgeon, I could be in Cleveland. And I could do surgery from Cleveland to somebody who is in Nairobi. And I kind of get where that science fiction would go. Somebody in Nairobi would put the stuff in, and then I'm in Cleveland, and I could get where that would go. For us, it's not even close, any place that we could go. But on the level of primary care, and some specialties that work by way of advice, and one would be psychiatry, the other would be neurology. Those are good, right? Nobody's cutting anything, touching anything. Even if Dr. Singh is putting in a 5mm hole, he still has to put in the 5mm hole. Those services have actually seen a boom in telemedicine. So telemedicine is, and I'll grab my phone. So you have a rash, okay? And you don't know what it is. So you are gonna get your phone and you're gonna dial in to a doctor who is going to then speak to you on your phone, and you'll say, okay, I have a rash, and the doctor will say, why don't you use your phone and take a picture of the rash and send it to me? Click, picture of the rash. Yes, I do think you have scabies, and I'm just making that up. I do think you have scabies, and what you need is X. That is actually out there right now. And I would say that sort of technology may work if you have a rash. And that sort of retail medicine that you can, get in the Price Chopper in Fulton, you can do that right now, works to a point. But I'll actually throw this to Dr. Bupuff as the primary care person in the room. Does that seem like a place to be without touching the patient?
Considering 90% of what we see probably doesn't need to be seen by a doctor anyway, telemedicine is good as anything else in primary care office. For example, your child has an earache, and you can't get to the emergency room, you don't want to go to the emergency. That's what it's basically for, reduce unnecessary emergency room visits. You can't get your doctor at 10 o'clock at night, so instead of going to the ER, you use the telemedicine service. The doctor you talk to looks at the child, the temperature's normal, he's kind of fussy, but he doesn't look too bad. You say to the mother, I think you can just provide some Tylenol and wait and call your doctor in the morning. So it saves an ER visit, the patient's being taken care of. That's where telemedicine, in my view, is probably indicated.
So that would be retail medicine. So you're paying to see a physician. But let's talk about telemedicine that happens in hospitals. So we are a rural hospital, and we are lacking in some services. So I'll choose neurology because that's a good one. Teleneurology is actually a very, very strong specialty. Again, what would happen is you would be in an emergency room like ours. You come in and you have symptoms of having a stroke. And what could happen then is our practitioners on our level would be able to, through a computer screen, roll that right into the room with the patient, and we will have a physician who is away from that facility, and that could be anywhere, and I'll choose Nairobi, it wouldn't be Nairobi. For New York State, you have to be New York State. But let's say you're in Queens, and at that point, the physician is able to speak to the patient, get the symptoms, see somebody examining the patient, direct the examination of that patient, and then would be able to give advice, maybe a diagnosis, whatever is necessary to treat that patient. So telemedicine in that realm is actually being used throughout the country. Another big area is telepsychiatry. Again, we can have a conversation without being in the same room. So that's a great place for telemedicine to be. So we're seeing a little bit more of that. It may be a while before you see telesurgery. So we probably won't be practicing. We'll be retired by then. But there may come a time when it's going to be exactly as you said. It's going to be Star Wars or whatever, and that's how we're going to do it.
The colony at moon.
You're going to do it.
So I was just wondering if all the surgeons on the panel, including Dr. Ruddy, perform colonoscopies, and if so, how frequently you do those?
So I no longer perform colonoscopies. Just want to put that out there for all my patients who are in the audience. But most surgeons do colonoscopies. Just so I can direct your question better, do you mean how often do people need colonoscopies, or how often?
Do they do that in their practice?
So on this panel, Dr. Ruddy is 2 days that she's doing colonoscopies. Dr. Holman does colonoscopies 1 day a week, and Dr. Sokolowski 1 day a week for the entire day. So that's a lot of colonoscopies. So that's how we do it. Star Wars, yes.
No forum with surgeons would be complete without asking a question that plagues big city emergency rooms on an epidemic basis. And that is, just as a point of curiosity, gunshot wounds. Has any of the panelists ever done gunshot wounds? And are all surgeons trained in gunshot wounds? And heaven forbid, not that I'm planning it, but is you able to handle a gunshot wound? Or would you just send them directly to upstairs?
So
Thanks for that bizarre question. It's really necessary.
it's a good question. So what's your name again? We just want to have that on record tonight. But so.
The plague in our country that, thank heavens, hasn't affected us this way.
So, as far as the surgical management of trauma, so Oswego Hospital is not a level 1 trauma center. We're a level 3 trauma center, so, or maybe even a 4. We don't see a lot of trauma. We're bypassed usually with trauma. However, we would see somebody who came in because somebody dropped them off in the ER, or they drove themselves to the ER. So I've been here probably the longest, so I've been here 16 years. I have not seen a gunshot wound in the entire time I've been here. Stab wounds, yes, but gunshot wounds, no. And the damage to the organs would be damage that we would probably see from anything else. And so we are all adept to deal with whatever we find, and adept at doing whatever needs to be done. I'll tell you, so training in Chicago, Washington, D.C., New York, I think we're good. I think we can handle some trauma. We're gonna be okay. We're gonna be okay. Okay, good. And what was your name again? Because we really need to make sure that somebody check on him tomorrow. Any other questions? Oh, I have one that I'm gonna go through at the end.
Well, I could just say it loud enough.
Okay.
I'm just wondering if there's anybody on the panel that has a procedure that they do repeatedly that they feel is completely avoidable if certain practices were done or habits were maintained or not maintained. And if there is a procedure that they feel that they do a lot that's avoidable, what is it?
procedure.
Which one?
Name a procedure.
Oh,
Name one, and it'll be the answer to your question.
So the gallbladder that I talked about before, that's a big one, where that's, you know, a lot of fat in the diet causing those, the buildup of cholesterol within bile causing the stones. So we see that a lot. There is don't get me wrong, there's a genetic component to practically everything, and there's one to that as well. But mostly, I would say that would be our number one thing that would really be preventable based on a change in diet and an increase in exercise.
And then skin cancers, obviously, if people did their.
That one to you, because you have to talk a long time about
No,
that.
I don't. I can talk very simply about it. Talking about things that you could avoid, you know, skin cancers and precancerous skin lesions. If people took care of their skin like they're supposed to, then we wouldn't have to worry about those sorts of things. And there's a lot of biopsies that have to be done to prove whether things are not skin cancers, and then those, once again, precancerous skin conditions that have to be dealt with so they don't progress into a skin cancer. So good skin care is way up there as well. And then for the guys here in their hernias, I mean, don't do anything that increases your intra-abdominal pressure. Don't lift heavy things. Don't become pregnant. Don't have somebody with a lung problem who is constantly coughing.
I hope they don't become pregnant. But if you do, Dr. Sokolowski will fix your hernia.
I think the one thing is, you know, this it is smoking. I tell you that the cigarette smoking, it affects every organ of your body. It can cause cancer almost to any organ of your body, as well as it does decrease the strength of your tissue, like hernia. Yes, you can have hernia because the tissue is not that strong, and then it does affect the healing also. It doesn't, patient don't have that good healing if, you know, we have a lot of cigarette in the body. So that's another lifestyle modification, you know, some little bit of exercise that I don't do but should be doing.
Is there some kind of ill eating or wrong eating that would cause breast cancer?
So there's not a wrong eating that would cause breast cancer. However, we do see an increase in breast cancer with an increase in obesity. So that, you know, that is the same as we would see in a lot of cancers, where obesity is contributory to that cancer. But there's nothing that you eat that would cause that, no.
What about skin tags? Do any of you or all of you do those in the office, or do they have to be done in ambulatory surgery?
Right, I mean, skin tags can certainly be done in the office because all you basically have to do, it's like a little mushroom there, you just go and snip it off. The main thing for skin tags is that the vast majority of insurance does not cover it because they consider it a cosmetic procedure. So that tends to be more the issue for individuals, is that they can't get it covered and they would have to pay out of pocket for it.
So I had a question here that I just want to address. So it was a question about how many surgeries that you have to do, and it kind of ties in with a question of could we handle the gunshot wound that may or may not come in. So one of the things that we go through in our training, it is very extensive. So normally 4 years of college, followed by 4 years of medical school, followed by 5 years of surgery. So that's the training that we go through to become general surgeons. And if you want to do anything more advanced, I'd say you want to do, well, different, I shouldn't say advanced. So if you want to do vascular surgery or newer surgery, that's more years as well. So we have really extensive training by the time we stand in front of a patient on our own. And at that point, we are ready and willing to do all that we have to for for the care of the patient. So for the question about how many various surgeries do you have to perform in a year, we don't have a set number, but as a group, I would say we are very cognizant of not doing surgeries that we don't do all the time. Because as with anything else, practice makes perfect. And so we like to have a lot of practice because we are actually sewing human beings and not quilts. So that's a big deal for us.
And the example of that is that I don't do colonoscopy. For the
It's not because you don't like it, though. It's
It's not because I don't like it. That's not the reason.
As I sat here and listened to all the different types of surgery, like mostly what you're talking about, do you ever do the regular, like say if you're doing a gallbladder, can you always do it that way, or can you do it otherwise? And how do you determine it before you do it?
So no, we don't always get to do it laparoscopically. The camera, that's great fun, but sometimes we just can't do it.
I mean, one of my teacher would say always is always wrong and never is never right. So yes, we try to do laparoscopically, and to some extent you can tell. Sometime depending on the duration of symptoms patients has had, like in terms of gallbladder, or based on sometimes they have a CAT scan, ultrasound maybe, but CAT scan maybe you can have an idea. But still we will try with the laparoscope, and only if we find it unsafe that we cannot do it safely laparoscopically, then yes, we do make a bigger cut to because nothing is done to compromise the safety. Ultimately, that's what matters. Yes, patient has to stay in the hospital for longer duration, but that's safer than doing something more disastrous.
I think you covered it.
Yeah, I was wondering, as far as this colonoscopy goes, is the regular what's it called, gastrologist, or?
Gastroenterologist.
Right, is he more qualified than a regular surgeon to look for more than a regular surgeon? Is he trained more? You know where I'm going with this?
I do. So, and I'll try to rephrase it for you. So, are you saying, is the question, is a gastroenterologist better at doing colonoscopies than a general surgeon?
No, he ain't doing good.
No dirty look here.
No.
So, as general surgeons and gastroenterologists, the title doesn't matter, the experience matters. So how many have you done, how long have you done that matters more than anything else. So Dr. Sokolowski, Dr. Holman, and myself, and again, I'll say I'm not doing them anymore, we have extensive experience doing upper and lower endoscopies. So with that experience, that is where you're going to get the value of the care. So you may have a gastroenterologist who is a year out, and then you have myself who's 17 years out. It would be very, very different. However, gastroenterologists do more procedures on average, right? So Dr. Holman is doing breast surgeries, gallbladders, hernias, etc. And she is scoping all day for 1 day, whereas a gastroenterologist will be scoping all 5 days, all day, or at least 3 of those days. So you have to go to the office sometime. 3 of those days all day. So they do have a little bit larger volume of patients. The second thing that I'll say about gastroenterologists when it comes to colonoscopies is that there are some advanced colonoscopy procedures that we don't do as general surgeons. So I'll explain one. It's called an endoscopic mucosal resection, or an EMR. And what that is you actually remove a very large polyp just using the scope. Mostly that is done not by every gastroenterologist, but by advanced gastroenterologists who can use the scope to remove a large polyp within the colon, and then you don't need our services to remove portions of your colon. So there's some things that they do better with advanced GI, but if we're talking about your run-of-the-mill screening colonoscopy, removal off your polyps, you will get the same service from general surgeons who do colonoscopy regularly as you would from a gastroenterologist.
Right, and this is where, this is where there's a good relationship between surgery and gastroenterology. If we're doing a colonoscopy and we find something that's best amenable for them to take care of, like one of those polyps, then they go to that appropriate physician, but somebody had to find it. And the same thing is true if the gastroenterologist is doing the scope and they find a large cancer that can't be removed, they then have to send to us. So each person can, participate in the diagnosis, and then the treatment goes to the appropriate physician.
Any additional questions? Oh, sorry, there's a question.
This time, are you doing the EMR here at our house as well?
So would we do an endoscopic mucosal resection here? So we have two advanced gastroenterologists, Dr. Roy and Dr. Sapkota, and they both do endoscopic mucosal resections. If, however, you need to have an endoscopic ultrasound, and I know that sounds weird, but let's say you have your colonoscopy, and then there is an ultrasound machine at the end of your colonoscopy, and they can look through all the walls of your colon. There's such a thing that exists, and it is not science fiction. We don't have one of those scopes. So if you do need an EUS, usually our surgeons, our gastroenterologists will have you have that procedure at Krause or Upstate, and it's a specialized machine that we don't own. But yes, they do other endoscopic mucosal resections right here.
When you were talking earlier about those H2 blockers or those PPIs, is one of the long-term effects of using those is the polyps in your stomach?
It definitely causes polyps in your stomach, but those polyps are not malignant, and they will never become malignant. They're called, they're just basically, they're called funding gland polyps, and they're completely benign.
They're not like colon polyps. They're different.
So let's say that you are taking one of these PPIs and H2 blockers, and they're designed to decrease the acid that's made by your stomach. So your stomach, independent thinker that it is, has decided that, hey, you're not going to stop me from making acid, mister, and this is what's going to happen. I am going to become bigger. I'm going to make a larger surface area to make more acid. And so that's how you get those polyps. They're just overgrowth of your normal natural tissue. And so, as Dr. Holman and Dr. Sokolowski say, they don't have any malignant potential. They don't turn into cancer. And we see them all the time, and sometimes we go back and we scope, and we don't see them anymore. They're gone. So that also is not unusual.
So if you had one, suppose somebody has one of those polyps, they do the scope and they see the polyp and they have it removed, how often should they go back and get another scope and make sure they don't have more?
It doesn't matter if you have more.
Okay.
They don't cause any discomfort or?
No.
No?
The important thing I think about that is, like Dr. Duggan said, is why it formed is the acid issue. So
Because
you're
it's forming more acid,
you're
yeah.
repeating the scope based on symptom control and other things that you're finding on the upper scope itself, not the polyps per se.
Just taking the time. Wow, we've been here for having a conversation for over an hour, which is awesome. does not cause polyps. I did not say that. I said what happens is that it's an overgrowth of the tissue because it wants to make more acid, not that acid causes polyps. We'll talk later. You and I, we'll talk. Okay, any other questions? Well, thank you all for being here. This was great for us. I hope it was